Good morning, everyone. My name is Dabney Evans. I am the co-chair of the IWAG Gender-Based Violence Sub-Working Group, and we're really delighted to welcome everyone this morning, afternoon, and evening during this exceptional time. Really grateful to everyone for making time in their very busy schedule within the context of all that's happening surrounding COVID. So I want to welcome everyone and thank you as a start. We're very excited for this session today, where we will have several speakers from WHO discussing the curriculum, which is on the topic of caring for women subjected to violence, with a focus on training for healthcare providers. And we're going to have several guests today joining us from WHO. So I'm going to start by unmuting them, and then I'll be bringing up the presentation. Our primary speaker today will be Dr. Avni Amin, who is within the branch at WHO focused on sexual and reproductive health and research. So bear with me as I unmute Avni, and I will be bringing up her slides. So Avni, I think you're unmuted. Our other speakers today will be Elizabeth Roche, also of WHO, and Anna Rita, and I'm trying to find you, Anna Rita. I see you. So I think you three are all unmuted, and I will now bring up the slide presentation to share with everyone. So Avni, can you give it a test?
Yeah. Hi, everyone. This is Avni. Can you hear me clearly? Hello, can you hear me?
Yes, we can hear you.
We can hear you.
Okay, perfect. Have you shared the screen, Dabney, or should I do it?
On it. Give me just 1 second.
Okay.
Can you see that?
Yep, I can. And I'll probably tell you next when I'm ready to move.
Great.
Okay, thank you everyone, and hope everyone is doing well and safe and healthy. I work in the Department of Sexual and Reproductive Health at WHO in Geneva, and I'm going to speak about the curriculum that WHO launched last December on training health workers on how to respond to intimate partner violence and sexual violence. The training curriculum is one of several implementation tools that WHO has put out after it published the guidelines for responding to intimate partner violence and sexual violence in 2013. Next slide, please. So just to say that from the time the guidelines were published to the curriculum, previous slide, please. We published several interim tools, job aids for health providers as well as health managers. So administrators at the district level, at the national level, subnational level, as well as hospital or facility administrators. And those two job aids, the primary ones that led or fed into the development of the curriculum, were the healthcare for women subjected to intimate partner violence and sexual violence, a clinical handbook, and strengthening health systems to respond to women subjected to IPV or sexual violence. And in addition, as part of our work on humanitarian, we also published in 2015 with UNODC, a strengthening medical legal response to sexual violence. And all of this in some ways fed into the development of the curriculum. And I'm going to speak now a little bit about the contents of the curriculum. Next slide, please. So the main objectives of the training curriculum have been to make sure that the participants, who are primarily health workers, have a general knowledge of violence against women as a public health problem, that they are able to, by the end of the training, demonstrate behaviors and understand the values that contribute to safe and supportive service cultures, demonstrate clinical skills on responding to violence against women, as well as knowledge of how to access resources and support patients as well as for oneself. The curriculum has 12 core modules and 2 supplemental modules. The 12 core modules start with a basic orientation and introduction understanding violence is a public health problem, uh, making sure that the participants understand what the survivors' experiences are, and also getting them to clarify their own values and beliefs and how they affect the care they give. Unpacking some of the guiding principles for providing survivor-centered care, beginning to develop provider and survivor communication skills, which is the basic foundation for offering first-line support, which we talk about quite a lot throughout the curriculum. Then session 5 covers when and how to identify IPV. Session 6 talks about first line support, and we've kind of broken it down into part 1, which covers listen, inquire, and validate. So the first 3 letters of lives. Session 7 covers how to build an ideal referral network and understand the legal and policy context. And then session 8 builds on the second part of lives, which is the enhancing safety and providing social support. The 9 and 9A cover the history taking and examination for sexual assault survivors. The 9A is a supplemental one for forensic examination, and this is largely where you will have people who are mandated in their countries to do forensic examinations. Session 10 is for everyone, which is the clinical care for survivors, so treatment and care for survivors of rape, focusing on the immediate first 5 days. And then session 11 covers documentation, and 12 covers basic as well as assessing survivors for moderate to severe depression and PTSD and referrals. It also has a small piece around self-care for providers. Next slide, please. So I'm going to give you a few highlights in each session. So in the orientation and introduction, one of the first things we do and one of the main activities in there is called Fears and Motivation in a Hat, which is, it's a very simple 20-30 minute exercise to start acknowledging that providers do have concerns and fears about caring for survivors, as well as they have many motivations and strengths. And so the whole purpose is to get them to talk about what their fears are and what their motivations are, so that the training can actually build on their motivations and strengths, as well as try to address some of their fears and concerns. Next slide. In the first session, the first substantive session of the training, we walk people through violence against women as a public health problem. And while we do talk about some of the global data, depending on the country context, we also encourage facilitators to bring in local epidemiological data about the prevalence and the health consequences of violence against women. And here we also start unpacking the role of the healthcare providers as well as their boundaries. And this is usually quite an effective thing to make sure and reassure providers that while they have specific roles and responsibilities, they do not have to do everything. And there are some very clear boundaries of things that they should not do. And this has a small video as well, including here, if there's time, we bring in some survivor stories through some online videos. Next slide. In session 2 is when we really start doing a lot of role playing and participatory exercises. And here, one of the exercises we've done often is called Blanketed by Blame, which is really putting the participants in the space or in the sort of role of the survivor and understanding the experience they go through from society, from professional duty bearers like the police or healthcare providers. And the main objective of this exercise is to really increase empathy for the difficulties that women who experience violence face when they're seeking help, to really have some discussion around how gender norms are affecting women's ability to seek help and access care, and then to encourage providers to start thinking about what they can do to offer an empathetic and empowering response. This is a picture of this exercise being done in Pakistan in the Khyber Pakhtunkhwa province. This was done in the context of a training for humanitarian communities. Next, please. In session 3, we build on the concepts that we've covered in session 2 on understanding the survivors' experiences, as well as we do a few values clarification exercise on providers' own beliefs. And here we start translating it into guiding principles of what that means in practice when they're providing care to survivors. And what we say when we mean that care has to promote principles of gender equality and human rights. So we bring in the rights language, the issues of equality in a very pragmatic way, and also have a discussion on what that would mean when they are communicating with the survivor of different choices. Next slide, please. In session 4, we start practicing provider-survivor communication skills. And since the first line support lives job aid is really focused on active listening, we do an exercise on active listening and reinforce some of the principles of an active listening approach using this mnemonic called SOLAR, which I think a lot of people in the counseling space use. This often leads to some interesting discussions in different cultural contexts of what is appropriate and what is not. For example, eye contact can be appropriate in some and not so appropriate in other cultural contexts. So it often sort of leads to some very practical choices and decisions people make on how to implement provider-survivor communication skills in the local context. Next. In session 5, we talk about when and how to identify intimate partner violence, what are the questions, direct and indirect, and how do you actually broach the subject. This often leads to a big, robust conversation around the WHO recommendation, which is to not do universal screening for intimate partner violence, but to do clinical inquiry and what clinical inquiry means. And we have a demonstration video where we show a provider actually asking questions to a patient based on signs and symptoms and role modeling clinical inquiry. Next slide, please. And then session 6 is where we start building skills on first line support. We walk them through each step of lives, specifically focusing on the first 3, the listening, empathetic listening, the inquiring about needs and concerns, and validation. And we pick from the job aids in the clinical handbook for providers each step and walk them through what the do's and don'ts are of active listening, what kind of questions you would ask to inquire about needs and concerns, and what kind of validation statements you could offer. And then we give people role plays or scenarios, and we ask them to practice the scenarios with one person playing the role of a survivor, the other the role of the provider, and then flipping so that each person gets a chance to practice the role play on the first line support, the first part of first line support, which is listen, inquire, validate. Now, depending on time, you can also, as facilitators, there is a script available. As facilitators, you can role play and demonstrate some good practices for offering first line support, and there is a video to also show how first line support can be done. And we usually, based on the advice we've received, we usually try and role model good practices and not role model bad practices. And that's based on the fact that we were told by the expert group in adult learning that it's better to actually have good practices role modeled while you're demonstrating this and getting people to practice. Next. In session 7, we start beginning to get, first of all, an exercise that helps people understand what are some of the challenges with how existing referral pathways are developed, and the difficulties for a survivor in accessing those referral networks. And to really, through this exercise, we just use it with a red wool ball. It's really to understand how uncoordinated referral systems can be quite burdensome for the survivors. But then the second part of that is that we get groups to work either within the provincial groups or districts or within the facilities to think of a simplified way in which they could build a referral pathway and how they could provide something called warm referrals. And so you, in the picture, you can see how the first part of the exercise is done with the survivor in the center trying to access all these different services. And then the second part, we ask them to actually redraw a map based on a template we provide, guiding them systematically on how they could do a simpler, more survivor-centered referral pathway. Next slide, please. Then session 8, we walk them through the lives part 2, which is focused on enhancing safety and facilitating social support using warm referrals. We present them the job aids for safety assessments and safety planning, as well as some of the tips for doing warm referrals. And then we give them vignettes or role plays again, the same ones. And this time we ask them to practice the whole role play from doing empathetic listening to offering and facilitating social support. So the whole lives process is walked once more or practiced once more through role plays. And here too, depending on time, there's a script available for facilitators to role model good ways of doing the whole lives scenario. Next step. Next step. Next slide, sorry.
Sorry, I'm trying to advance it. It's not advancing. There we go.
Okay. In session 9, we switch to focusing on survivors of sexual assault. And here we walk them through step-by-step process from the clinical handbook on how to do history taking and how to do what are the things to consider in a medical examination. For survivors of rape, we have earlier been using the clinical management of rape survivors e-learning to show some of the steps. But as many of you probably know, this e-learning is now being updated. The new e-learning that will come out soon will have clinical management of sexual assault as well as clinical management of IPV, and Elizabeth can talk a little bit more about that. But here we actually show people some of the ways in which you do good history taking and what you consider in medical examination. And then one more exercise that is built in is another role play with vignettes so that people practice a good history taking as part of the sexual assault examination. Next slide. In the session 10, clinical care for survivors of sexual assault part 2, we focus on the treatment and care. We show them the algorithm or treatment pathway for survivors of rape within the first 5 days, and then we give them small vignettes and a table with different treatment decisions that they have to make based on that particular vignette. And people are usually split into groups and asked to fill out the tables and then explain which treatment they have recommended, which tests they are carried out based on that particular scenario that has been given to them. And it leads to just some discussions around what is needed, what is not needed, depending on the scenario. And it's a very easy, short 20-minute exercise to do. Next slide. In session 11, we talk about the principles of documentation for both sexual assault and IPV. We show them the forms from the clinical handbook and the health manager's manuals on intake forms as well as sexual assault forms where they are supposed to record the history and the examination findings. We walk them through some of the tips for documentation, including the tips for maintaining privacy and confidentiality in record keeping. And we give them one of these forms in an A3 format and ask them to work in groups to discuss based on case scenarios as to how they can, what they would fill out and what they would not fill out for that particular case scenario. So they begin to get a feel for how to fill these forms out. Next slide. And this is the second to last slide. So in session 12, which is focused on mental health care, whereas first line support has really focused on psychological first aid, and that's what WHO recommends is the absolute minimum. The care for mental health uh, has an additional component on more advanced psychosocial support, as well as assessments, how to do assessments for moderate to severe depression and PTSD, and what treatments are recommended. Usually in primary health settings, a lot of times it's more referrals for this type of care, although many of them do have the ability to at least provide some basic psychosocial support. We have videos from MH Gap that we provide links to in this session. We do some stress reduction exercises, which are both to demonstrate to survivors, as well as we discuss ways in which providers can themselves do some self-care. And here is just one in the session. It's just one exercise that we start with in this in terms of a true and false to get people to think about the issues that they have to address when thinking about mental health care. Next slide, please. So just to close off, I wanted to just flag that in addition to the curriculum, we also have materials to help sorry, next slide, previous slide, and I'll close. We also have materials online for monitoring and evaluation of trainings, which includes in the health manager's manual, there's a list of indicators. And on the website where the curriculum is there is a small link for evaluation tools, which includes a survey of knowledge, attitudes, and practices for providers, a facility readiness checklist. And then in addition, if people want to do documentation of cases, then the health manager's manual has a one-page intake form for doing data collection and data aggregation in health management information systems for cases of violence against women that they identify. And with this, I'm going to hand over to my colleague, Anna Rita Ronzoni from our EMRO office, who will speak to some of the experiences in rolling this curriculum out in the field. Over to you, Anna, and thank you very much.
Okay, thank you, Avni. Can you hear me? Can
yes.
Everybody hear me? Yes. Okay, very good. So as Avni said, my name is Anna. I am the Gender-Based Violence Technical Officer for the Eastern Mediterranean region based in Cairo. And I'm going just to show you the implementation of the curriculum in our region. So Davni, if you can just go to the next slide. Okay, so this is of course, the map of the countries that are under the Eastern Mediterranean region, and the one in dark green are the countries where the curriculum is fully implemented, and then the one in lighter green are the countries where we started some activities and without the implementation of the curriculum. And the other countries, as you may see from the chart, we do not have currently activities on violence against women. So since the start of the curriculum, so when the clinical handbook was published in 2014 up to today, we had overall more than 70,000 health professionals, including frontline health providers and managers trained on the curriculum. Out of the 7,000, a huge number was trained in Pakistan and in Afghanistan, with Pakistan actually being the first country where the curriculum was tested and rolled out. And then Afghanistan, where a national protocol for gender-based violence was actually drafted and endorsed. We focus while training our health providers, as Avni said, on first-line support, clinical management of rape, and then mental health for GBV survivors. And recently also we started some work on community awareness for GBV, particularly in Syria, and some work is also running in Iraq, as well as a safe referrals. We had a very nice joint training with UNFPA in Jordan for the Syrian response. So if we can go to the next slide. So using the monitoring, the evaluation tool that you will find in the curriculum, we try to measure the participants, and these are some data from our trainings in Iraq and in Pakistan. When we asked to them after the training what were the most valuable things learned, their answer were to be ready to deliver the service, so the readiness part, and how to communicate with survivors in a respectful way, in a proper way, and to take every GBV case seriously, because often GBV cases were like left behind, and also very first-line support, and how to listen, to respond to each survivor again appropriately. And in general, they had a better sense and a better eye and gender equality, and how as health provider and so as reference for the community, they can themselves promote the idea of gender equality and women's rights. And I have to say that among all the package, the active listening and the lives, the first line support, were the topics that really found very interesting, and they can immediately apply in their work. And also how to control reaction and not being judgmental. And this last part linked very much to our work during the training, also to change their attitudes and behaviors. We know that is a very long process, but during the 3, 4, or 5 days training, we have seen some changes in the perception of survivors and also in the perception of their role. So in the curriculum, we have a part to monitor the change in attitudes and behaviors, and I just pulled three examples. Like the first one is the wife's obligation to have sex with her husbands, and we noticed that the level of agreement to this was decreased during the after the training. And also in terms of roles and gender roles and responsibility of women, like taking care of the family, this also we notice a decrease in the agreement with this statement. And also, and the last one, a wife should obey her husband even if she disagrees. Also, we notice a kind of a change in the perception of women roles within their societies. Then during the training, we also run an exercise which is identifying barriers in providing care. And I have to say this is cross-cutting among all the countries in our region. Of course, access to medical care, both in terms of how to reach the premises, and in fact being able to act one of this identified barrier. Then mandatory reporting, we know is a very hot topic in our region. So this prevent women from disclosing their sexual violence, and also families prevent to the health premises, to the health facilities to receive life-saving intervention. Of course, the lack of staff trained on GBV and the rotation of the staff was identified as one of the main barriers, and the lack of proper equipment inside health facilities, and including also not having the space to a confidential space to run a confidential conversation with survivors. And in general, lack of awareness of gender-based violence within the community. Also, this was a barrier. And, you know, protection and psychological care. So the kind of non-judgmental approach that was gender one. The next one is some testimonies we collected from the different from health providers who participated to our training in the different countries. And the first one is from a midwife in Afghanistan, and talking to them, we realized that what it really changed for them is the perception of what it means to ensure confidentiality for survivors, even like talking among the different health providers of the case, and how much this can expose survivors to additional harm and threat to their lives. Also the culture, so how to change the culture of health facilities, like the director of general health really talked about the need of changing the cultures of health facilities. And this is also why when we train, we do not train only health providers, but also we do target health managers. Then also during the training, we have a lot of disclosure from health providers of stories of survivors. These usually happen during the second or third day when they feel more comfortable. And in Syria, one of them referred that survivors say that I have to bear a lot of burdens in my life, but today I live in dignity, trust, and hope. And last one from Sudan, sometimes talking about domestic violence, spousal violence, intimate partner violence, however you want to call it, it's even more difficult than talking about sexual violence because it goes inside the family issues. So, for example, this director in Sudan said that is still a big taboo, much more than talking about sexual violence. And he talked about his intention and his willingness to be able to know how to respond to them. This is all from my side. Just wanted to give you a brief, a brief understanding of what is going around in the region. So now I think I'm passing to Elizabeth, right?
Elizabeth, are you there?
Can you hear me now?
Yes, now we can hear you. And I think, go ahead, Elizabeth.
Great. So I think just to thank everyone for the presentations and for the sharing of experiences from the Middle East region, and also to Avni for all the work that has gone into the curriculum. I know it's been quite a labor of love. I think we'd love to take some questions right now. So I know that everyone has a chat box by them. If you could either chat box your question, or Dabney, maybe we can unmute folks so that they can speak directly. And just to say very, very quickly, I know we've been rolling out quite a bit of guidance lately. And I just wanted to say that there's a lot of harmony between different pieces of guidance that WHO has. So as has been mentioned, we have been in the process of updating the clinical management of rape guidance. And that now is inclusive of clinical management of rape and intimate partner violence survivors. And there's a lot of agreement between that and the clinical handbook. And we have been using the curriculum in regions where we're also rolling out that guidance in humanitarian settings. So just to say that these are kind of harmonized tools that look at how to provide care to survivors across a variety of different settings. All right, and with that, we would love to hear questions, comments, anything from the participants.
Thank you so much, Avni, Anarita, and Elizabeth. I'm going to take the bold move of unmuting everyone, and I'm sure everyone will clamor with questions. Feel free to unmute directly. I'm unmuting everyone now, or if you prefer to type your question into the chat box, that's also an option.
مثل ما قلت لك فارس، هذا القرار بيرجع لكم، هذا قرار على صعيد المنظمه، انتم كيف بدكم تعملوا اولويه من بين، يعني تعملوا priority من بين البرايورتيز اللي عندكم اياها، هذا بيرجع لكم. انا بس اللي عم جرب اقوله انه ممكن يكون في امكانيه
I do see that we have a question in the chat box from Elena, and the question has to do with FGM. Is this included in any of the sections? And if not, why was it excluded? I'm specifically thinking about Sudan, in which the curriculum was rolled out and the prevalence of FGM is so high.
Daphne, do you want me to respond for each question, or should we wait till we collect a few questions? I'm happy to respond on the FGM piece.
Yeah, please go ahead and respond to that. And if folks want to type their questions into the chat box, that would be great. And now that I've unmuted everyone, if you are in a circumstance where you have background noise, if you want to mute yourself, that would be appreciated. But please go ahead, Avni, on the question about FGM.
So just to say that WHO has separate guidelines for healthcare workers on management of FGM and management of complications for FGM. Similar to what we've done for violence against women, for specifically for intimate partner violence and sexual violence, there is actually a clinical handbook for women living with, for management of women living with FGM, and training materials also for that. And I'm happy to share the links to those materials. So it's just that, you know, the materials for violence against women are for all regions, regardless, and we've dealt with the FGM issue in a separate set of guidelines and implementation tools. So they are covered.
Avni, may I add something?
Yeah.
For Sudan, because Sudan was mentioned. So yes, also recently what we have been trying to do with Sudan, because when we talk about implementation of GBV in WHO, we more talk about, or we try also to do integration of GBV, like for example, in mental health or sexual reproductive health. So what we are trying to do also in Sudan is whenever there is a training, for example, on FGM, to include some slides or half a session on gender-based violence as well.
Thank you. We have another question in the chat, couple of questions coming up. I'll maybe read a few questions out here. So one question from Yvonne asking about sanitary napkins and perhaps menstrual hygiene management within the curriculum, whether there's any conversation about that. And a second part of that question has to do with whether, with relation to access to abortion services. Maybe perhaps I'm reading into the question, but perhaps in under circumstances of sexual violence. We have a question from Bill Powell. Hi, Bill. When the updated clinical guidance will be released? And another question with regards to COVID-19. Do we have key messages and additional guidance for healthcare providers in this circumstance? So maybe stop with those three questions and then gather a few more if you all want to react.
Maybe Elizabeth, do you want to answer the question on the updated clinical management of rape and IPV? Because that's something you should answer, and then I can answer some of the others.
Sure. So for the clinical management of rape and intimate partner violence survivors, that guidance is done. It is just awaiting being put up on our website. So we should be sending around an email announcement with the link in probably the next week or two. So I'm very happy to share that news. The link will go exactly where the current clinical management of rape is. So we'll just update the hyperlink so you can access it there. But be on the lookout probably in the next week or two for that.
Okay. Maybe I'll answer the question of sanitary napkins and access to abortion services. So we have colleagues in our department who have been working on issues of sanitary napkins and menstrual hygiene, particularly focusing on adolescent girls, but not only. So we can refer, if people have questions, I mean, I'm happy to just refer to those materials and to those links that we have and to the colleagues who are working on these issues as part of our adolescent sexual reproductive health program. Then with respect to access to abortion services in in session 10 in the clinical treatment of sexual assault and rape, and this is also reflected in the clinical handbook, is there is a reflection and a recognition that sexual assault can result in pregnancy, and depending on the legal context, that care should be safe abortion services should be offered in to the full extent of the law, and of course then the links to the safe abortion guidelines and materials are also available.
Fantastic. We have a bunch of questions rolling in now. I will just point out to everyone.
Oh, and sorry, I forgot the COVID one. Just maybe to flag, and Anna Rita can also speak to that. We are aware that this is the issues of, the recommendations to stay at home. All of this can increase risk for women who are in abusive relationships. So WHO is working on a statement and some messages around COVID and GBV and what healthcare providers can do. And in fact, right after this call, we'll be actually trying to pull some materials together. So watch the space, I suppose, is what I can say.
Thank you so much. Anna Rita, did you want to add more to that?
No, just that also as a regional office, due to the, what is happening also in the region from humanitarian perspective, we will also add, observation regarding women refugees or women IDPs, and how these further impact, together with COVID, they increased risk of exposure to violence.
Thank you. So we have a lot happening in the chat box right now. Thanks to everybody for these great questions. Just so everyone is aware, Elizabeth has added a link to the clinical handbook for FGM. So if you look back at the chat, you'll be able to see that link. A few other questions coming now. So one from Claire is, in the package of resources, do you have any best practice considerations about mandatory reporting or for child survivors of GBV? A second question is the curriculum designed to be rolled out by others aside from WHO? And if so, which profiles are suggested for facilitators? And then we'll take one more question in this set, which is how to support women and girls requesting virginity testing, not providing it, included in the curriculum. The question is that included in the curriculum?
Okay. All right. Should I, does anybody else, do any of my colleagues want to answer any of these? Otherwise, I'm happy to take whichever questions you'd like me to. Anna Rita, Elizabeth?
Sure, go ahead.
Okay. So maybe just to say that with respect to mandatory reporting, our guidelines, and this is also in the clinical handbook, which is usually we encourage trainers and facilitators to make that accessible as a job aid. We're very clear that WHO doesn't recommend mandatory reporting for adult women. We make that recommendation quite clear. This often for a lot in countries where this is in place for adult women, this obviously poses many challenges. So this is something that actually requires advocacy and discussion at a more policy level, because healthcare providers often face the dilemma that, if the law requires it, they have to do it. Now with children, we have guidance on this in the Child and Adolescent Sexual Abuse Guidelines, where which was also mentioned in the toolkit, in the tools that I presented. But it's basically that obviously where there's mandatory reporting for children and child and adolescent sexual abuse survivors, there are three considerations. The first consideration is if the law requires it, then obviously it has to be done. But we usually say that the informed consent process requires providers to actually say this to the caregiver if it's a young child or to the adolescent. and to explain what we call the limits or boundaries of confidentiality. Secondly, that as part of the reporting process, that the healthcare providers do a safety and well-being assessment. So really making sure that in the reporting process, the safety is not compromised or that safety considerations are taken into account. Where mandatory reporting is not in place, but the healthcare provider feels ethically obliged because of safety issues, or the particular institution or healthcare facility mandates the provider to do so. Again, the most important consideration for children is the safety assessment and informed, what we call the boundaries of confidentiality need to be explained clearly to the caregiver, or to the adolescent survivor, that this is something that the law requires it to happen. We have, in training, we have a lot of discussions, a lot of very thorny problems, particularly in countries where teenage pregnancy rates are high, and age of sexual consent often results in a lot of adolescents ending up with statutory rape requirements, which require them to be reported. And we do say that in the child and adolescent sexual abuse guidelines that usually if two adolescents are engaging and in a similar age group in a consensual relationship, then unless the safety is at risk, we need to follow the international human rights standards, which require that care and treatment must be provided regardless. Reporting what is consensual sex between two consenting adolescents is not necessarily in line with some of the international human rights standards. So this is spelled out in the child and adolescent sexual abuse guidelines. Then with respect to whether it's designed to be rolled out only by WHO or by others, no, it's actually designed to be rolled out by anyone. The facilitator guide is very much step-by-step instructions. All the exercises that we have are also step-by-step instructions, and there's a slide deck that allows other people to pick it up and deliver the training. The other thing is that the criteria we usually, in the introduction of the facilitator manual, there is a specific set of criteria given for facilitators, and usually we say it has to be somebody, we usually say, where you're training clinicians, try and get clinicians because peer-to-peer clinic training is usually more effective. A doctor is more likely to listen to a doctor, a nurse more likely to listen to a nurse. So to really have such a multidisciplinary facilitator team, plus somebody who understands the basic of gender, also, so you'd need at least one person, and we say a team of two, at minimum two facilitators, and of course you can have more than two, but those criteria are spelled out in the facilitator manual. Then with respect to virginity testing, we have again, this is spelled out in both the clinical handbook as well as the child and adolescent sexual abuse guidelines. The WHO does not recommend virginity testing on many grounds. It's scientifically not valid, a human rights violation, causes distress for many. And the basic premise is problematic. There is a clear recommendation to not do it, or what people call two-finger test or per vaginal examination. And we have an interagency statement which was published with several other UN agencies that also very clearly states that virginity testing or two-finger test should not be conducted on any grounds, including for survivors of rape.
Thank you so much. We have a few other questions that are still popping up. So
Okay.
Karina asked whether there were links to the manuals for the management of child and adolescent survivors. And a little further down in our text box, you will see that Elizabeth has posted the clinical and policy guidelines for child and adolescent survivors of sexual abuse. So hopefully that's a resource that everyone can take advantage of. We have another question from Alessandra, who says, we know that women and girls with disabilities face greater risk when it comes to violence and abuse, but often training resources do not present a disability inclusive perspective. Could you please share if the materials presented include a disability inclusive perspective? And if not, would you be interested in discussing how to ensure this can be done in future to make sure that women and girls with disabilities that are survivors of violence are not left behind and can be fully supported by health workers? A second question, it has to do with supply chain and logistics. Could you let us know what kind of supply chain and logistics challenges you experience in your day-to-day activities, given the tough geography and remote locations of beneficiaries? And given that most of the medical supplies might be perishable, how does this add to inventory and warehousing challenges?
Okay. Just asking my colleagues, Elizabeth and Anna Rita, and I don't know who else is online, if they would like to answer any of these questions.
Maybe just give some experience from field for the second question.
Yeah.
Yeah, you can please go ahead with the first one, and then maybe I can.
Okay, so I think Elizabeth already provided the links to the child and adolescent sexual abuse guidelines. Then for the disabilities one, at the moment, these materials do not address women with disabilities, though we recognize very much that they are disproportionately at risk of violence and affected by violence, as well as in terms of access to care. This is an area, so we very much welcome a discussion afterwards on how these materials could be made more relevant and take that perspective into account. I am aware that one of the Australian collaborating centers in, which is Monash University, there's a Center for Gender and Health that has actually done some work on taking the WHO guidelines on this topic and addressing some of the disability issues and adapting it. So one thing is to obviously for us to look at that and see what materials they've produced, but we would very much welcome any additional discussion on how these could be made relevant for women and girls affected by disabilities. And then the supply chain issues, just to flag that this comes up a lot, particularly when it comes to availability of things like emergency contraception, PEP, and STIs is a little less because it's usually antibiotics. But we have in the health manager's manual, which I mentioned as a resource, there is a list of, in chapter 5, there is a list of all the essential commodities and supplies, right from medicines to job aids to sanitary napkins to clothes, etc., that are listed as requirements. And this comes from the WHO essential commodities guidelines at different levels, primary, secondary, tertiary level facilities, which we compiled, as well as from the medico-legal guidelines, medico-legal guidance for sexual violence. And one of the things that we usually end up facing in the field, and Anna can speak more to that, is which of these are included in the National Essential Medicines list. And I know that we faced this for Afghanistan, where emergency contraception was not included in the essential medicines list. And so there was a lot of advocacy that had to be done to make sure that emergency contraception was available. And during the training, what we do is we ask, because if emergency contraception is not available through the essential medicines list in the government system, then we usually go to the plan B, which is the high dose combined oral contraceptives, or IUDs. This is one of the big areas where we face questions on supplies and logistics. Over to you, Anna.
Yeah, no, I want just to add that apart from the drugs and all the points you flagged already, Avni, there is also a lack of minimum, like basic standards in place to actually not only respond to sexual violence, but to have a confidential conversation with survivors. So there is no private space, and therefore there are no minimum standards in place to identify survivors of gender-based violence. So, for example, some countries, as Afghanistan, they provided to I think more than 500 or 700 facilities with curtains to ensure minimum privacy. So it also, this aspect is also very important and impacts very much, along with the drugs, the issue that Avni already mentioned. And in our quality assurance tool that Avni also mentioned during the presentation, we do have a series of questions of what are the minimum requirements that should be in place to, one, inquire about suspected gender-based violence, second, to actually respond to GBV survivors.
Just to quickly add, there's also been quite a bit of work done at the global level to ensure that supplies are available in humanitarian settings. So just quickly to say that there is a PEP module of the Interagency Emergency Health Kits, and there are post-rape treatment supplies, treatment and supplies in the reproductive health kits sourced by UNFPA. So there are some globally available supply lines for folks working in humanitarian settings, which is part of an effort to make sure that these supplies are available.
Yeah. Maybe in the health manager's manual, actually, there's a whole discussion in addition to a checklist of all the commodities, or the PEP kits, the rape kits, all of them are mentioned. And where they can be procured. One of the issues that obviously we do ask people to consider is it's difficult for forecasting because a lot of times not all, if you have pre-packaged rape kits, not all of the products get consumed and then that results in a lot of waste with expired products in a pre-packaged kit. So we also say that, there needs to be some assessment of what the need is so that you don't end up wasting prepackaged kits, but also most of the things that are in the kit, apart from PEP and emergency contraception, a lot of them are basic supplies that facilities would have, and some of them are as basic for forensics as nail cutters or scissors or swabs and things like that, which then people need to think about forecasting and predicting. And there is some guidance on that, drawing on some of the other health systems guidance for how to do forecasting. So it is covered in the health manager's manual.
Thank you. I know we are at time. We have one final question, and I want to mention just one other conversation that was happening in the chat box if people didn't happen to notice it. So Sarah Martin shared that the GBV community of practice is gathering COVID messaging, and she shared her email address, which is gbvcop@gmail.com, if you want to join the GBV AOR community of practice. And she's also shared a link for the Dropbox where those messages are being compiled. So those things appear in the chat box. We have one final question, and I know that Rania has been waiting very patiently, so I want to make sure we get that in. The question is how the curriculum could be tailored for other settings, for example, for social workers or for schools. So if we could ask our presenters to answer that question as a final wrap up, that'd be fantastic.
Hi. So maybe just to say that social workers, I think the big focus of training social workers is usually the first line support. And we have included social workers in our trainings in Eastern Southern Africa, particularly in Namibia, where social workers form a big cadre of staff that, in addition to nurses, are doing a lot of the linkages to referral services. A lot of the mandating of mandatory reporting requirements for both adolescents and children often fall on social workers. So we've usually done trainings where you have teams of doctors, nurses, and social workers, or you could have teams of doctors, nurses, midwives, and really thinking of a system of dividing the roles and responsibilities of who does what and which, and then doing the training accordingly. But lives is something that I think all social workers can be offered to provide. Obviously, the clinical management of rape and sexual assault, the clinical parts are more relevant for physicians and in some settings, nurses. But lives is something that we say everybody can be offered and trained together, including, the referral, how to do referrals, how to do safety assessments, etc. And then for schools, it's a little bit tricky because, again, we don't advocate schools to go actively asking students about sexual assault, but if it does, some of the basic principles of empathetic listening, asking, what the adolescent or child wants, making sure that they know, how to do what we call quote unquote warm referrals, being validating and non-judgmental. I think a lot of those are very basic principles of good communication. We've never tried it with schools and teachers, but I mean, if somebody wants to do it and tell us what the experience is, we'd welcome that feedback. I just think you have to be careful for some of the clinical parts, including clinical inquiry, which is obviously only supposed to be done in clinical settings. I think the other issue that we worry about in community settings, such as schools or, for community outreach workers, is that we feel that it's better for those groups to really spread the message around awareness raising and connecting them to services where you have trained healthcare providers. I think the safety is such a key issue in community settings, including in schools, where if you can't ensure safety, then it's just a real challenge to do any proactive asking. So it's better that if there is a disclosure received, then the provider, the teachers, or the school counselors at minimum know what to do and where to send in a safe way. Focusing at that point, at least on some of the principles of first line support communication. And also, to be able to raise awareness that this happens, this is health consequences. If anyone needs help, they should raise it in a confidential way with X, Y, and Z, who presumably has to be trained to be able to handle that. But I wouldn't really go into beyond that, any more proactive asking in schools or in community settings, just because of the safety issues.
Thank you so much. Again, I want to thank everyone who's joined us on this call, especially our presenters, Dr. Avni Amin, Elizabeth Roche, and Anna Rita. We really appreciate you sharing your expertise. I know that an active chat has still been going on, and I want to let everyone know that the recording of this webinar will be available on the IWAG website, which is iawg.net. We have a page for the subworking group on gender-based violence, and the recording will be housed there probably by the end of this week. So if there are others that you think should take a look at this webinar that would benefit from the information, please refer them to that page in just a few days, or maybe next week, given all the other things that we're all managing right now. Thanks again so much to our speakers, and thanks to everyone for joining, and stay well.
Thank you.
Thanks, everybody.
Bye.